Your dentist has been trying to warn you about your heart for years. Not in those words, probably not even intentionally, but every time they looked in your mouth and noted gum disease, bacterial overgrowth, a tongue coating thick enough to scrape, they were looking at a risk factor for something that has nothing to do with teeth. Chronic heart valve inflammation, infective endocarditis specifically. A condition where bacteria colonize the heart's inner lining and valve surfaces, triggering an immune response that over time can destroy valve architecture, impair cardiac function, and in its most serious presentations, kill. A meaningful percentage of cases that develop in otherwise healthy people, people without prosthetic valves, without prior heart disease, without obvious risk factors, trace back to a microbial source that most people interact with every single day, the mouth. And more specifically, a sublingual pathway that barely gets mentioned outside of cardiology journals. Let me trace the root, because the mechanism is specific enough that once you understand it, the tongue-to-heart connection stops feeling improbable and starts feeling almost obvious. The oral cavity is one of the most bacterially dense environments in the human body. Somewhere between 600 and 700 distinct species have been identified in the human oral microbiome. Most of this population is commensal. It belongs there. It contributes to oral health, outcompetes pathogens, participates in early digestion. But the balance is fragile, and when it shifts through poor hygiene, dietary changes, antibiotic disruption, systemic illness, certain species that were minor players become dominant. And some of those species have a specific, well-documented pathological relationship with the cardiovascular system. Streptococcus mutans is the one most people know in a dental context. It's the primary driver of tooth decay, but its cardiac implications are less commonly discussed. S. mutans produces surface proteins that allow it to adhere to damaged or inflamed heart valve tissue with remarkable efficiency. Once it reaches the heart, it doesn't just sit there. It activates platelet aggregation around itself, building a protective coating of clot material that shields it from both the immune system and antibiotics. The resulting lesion is called a vegetation, and vegetations on heart valves are, in cardiology terms, a serious structural problem. The question is how bacteria get from the mouth to the heart in the first place. Bacteremia, the transient presence of bacteria in the bloodstream, is more common than most people realize. It happens during dental procedures. It happens during vigorous chewing. It happens during toothbrushing. Anytime the mucosal barrier of the mouth is disrupted, even momentarily, bacteria from the oral cavity can enter the bloodstream in small numbers. Under normal circumstances, the immune system clears this quickly. Transient oral bacteremia in a healthy person is largely inconsequential, but in people with pre-existing valve irregularities, even mild ones, even ones that were never diagnosed, the hemodynamic turbulence around an abnormal valve creates attachment opportunities for circulating bacteria. The surface, already slightly damaged by irregular blood flow, provides footholds, and certain oral bacteria have evolved through extended coevolution with human hosts to exploit those footholds with impressive specificity. The tongue is where this story gets more specific and more actionable. The dorsal surface of the tongue, particularly the posterior third, is one of the highest density bacterial reservoirs in the entire oral cavity. The filiform papillae, those tiny projections that give the tongue its texture, create a complex three-dimensional surface structure that traps epithelial cells, food debris, and bacteria in ways that are genuinely difficult to disrupt by normal saliva flow or even standard toothbrushing. The tongue coating that accumulates on this surface, the white or yellowish film that's thicker in some people than others, is not superficial contamination. It's a biofilm, a structured community of microorganisms living in an extracellular matrix they've collectively produced. And within that biofilm, in people with disrupted oral microbiomes, the proportion of pathogenic oral species, including Streptococcus species with cardiac adhesion proteins, is strikingly high. A study published in the Journal of Clinical Periodontology examined bacterial composition of tongue coatings in patients with confirmed infective endocarditis. The pathogenic oral species present in tongue biofilms of endocarditis patients weren't different in kind from what healthy controls carried. They were different in dominance. The same species, in greater relative abundance, in a less diverse microbial community. The protective diversity of a healthy oral microbiome had eroded. The potential cardiac pathogens had filled the gap. You know, there's a term in microbiology called dysbiosis that gets used for the gut quite a lot these days. The oral microbiome equivalent, oral dysbiosis, doesn't get nearly the same attention, despite the fact that the mouth is the entry point for everything that reaches the gut, and is itself a system with profound systemic implications. Oral dysbiosis doesn't just raise infection risk, it raises inflammatory tone. The bacteria in a disrupted oral biofilm, particularly the gram-negative anaerobes that proliferate in oxygen-depleted tongue coating, produce lipopolysaccharides, LPS, fragments of bacterial cell wall that the human immune system treats as a direct threat signal. Even in subinfectious quantities, LPS entering systemic circulation via the sublingual vascular network triggers inflammatory cytokine production. Persistent, low-grade, but real. The sublingual region, underneath the tongue, has one of the highest vascular densities of any mucosal surface in the body. It's why sublingual medication administration works so well for drugs that need rapid onset, nitroglycerin for angina.
Certain blood pressure medications in emergencies, the capillary network under the tongue absorbs directly into systemic circulation efficiently, quickly, which means whatever's happening on the surface of the tongue and in the biofilms sitting on it has an unusually direct route to the bloodstream, not just during acute disruption events, continuously, at low levels, as the mucosal barrier interacts with the dense microbial community directly about it. For a heart valve already working against slightly abnormal hemodynamics, maybe a bicuspid aortic valve, which affects roughly 1 to 2% of the population, often without diagnosis, this continuous low-level inflammatory and microbial input is, over years, a quiet burden. The endocardium responds to inflammatory signaling. Repeated insults to valve tissue, even subclinical ones, produce fibrotic changes. The valve thickens slightly, becomes less pliable. The surface becomes irregular, which creates more turbulence, which creates more attachment opportunity for any bacteria that make it through. It's a slow spiral, and it runs mostly silently. The clinical recognition of this pathway is actually older than most people realize. The connection between dental health and bacterial endocarditis has been known since the early 20th century. Antibiotic prophylaxis before dental procedures, which many people with known valve disease still receive, exists specifically because of this mechanism. What's newer, and what changes the practical implications significantly, is the understanding of the tongue's specific role as a bacterial reservoir and the sublingual route as a continuous rather than episodic exposure pathway. Earlier models focused on acute events, a dental extraction, a cleaning procedure, a moment of significant gum disruption. The updated model accounts for the chronic, low-grade trafficking of oral bacteria through a highly vascular mucosal surface that never really stops. Believe it or not, tongue scraping, which gets dismissed fairly regularly as a wellness trend without a scientific basis, has genuinely interesting data behind it. A 2004 study in the Journal of Periodontology compared the effect of tongue scraping versus brushing on bacterial populations on the tongue dorsum. Scraping was more effective at reducing volatile sulfur compound-producing bacteria in the posterior tongue coating, which correlates with both halitosis and oral microbial dysbiosis. More recent sequencing work has shown reductions in pathogenic species abundance that persist for several hours post-scraping. Several hours isn't a cure, and I want to be careful about overstating the cardiac protection implications of a tongue scraper. Nobody has run a randomized controlled trial showing tongue scraping reduces endocarditis incidence. That trial would take decades, but the mechanism doesn't require that trial to be worth paying attention to. The tongue is a high-density bacterial reservoir. Those bacteria have access to systemic circulation via the sublingual vascular network. Certain oral bacteria have documented cardiac adhesion mechanisms. Reducing the bacterial load on the tongue surface is a reasonable mechanical intervention in a chain that, in its worst case, ends at a damaged heart valve. The indirect evidence is consistent enough to take seriously. Periodontal disease, gum disease, has the most robust epidemiological evidence linking oral health to cardiovascular outcomes. Multiple large meta-analyses have found statistically significant associations between periodontitis and coronary artery disease, stroke, and endocarditis. The American Heart Association has issued statements acknowledging the association between periodontal disease and cardiovascular disease. The mechanistic plausibility is high enough to dismissing the association entirely requires ignoring a lot of biology that hangs together quite coherently. What the tongue-specific research adds is a mechanism that's been underweighted, not just the acute gum disruption events, but the continuous sublingual seeding from a bacterial reservoir that most people's oral hygiene routines don't touch. Toothbrushing reaches the teeth and gums. Flossing addresses the interproximal spaces. Mouthwash reaches the accessible mucosal surfaces. The posterior tongue dorsum, behind where most brushing strokes naturally reach, sits there accumulating a biofilm that can reach several millimeters thick in people who don't actively address it. And in that biofilm, the organisms with the most documented cardiac pathogenic potential, the Streptococcus viridans group, the S. mutans strains with cardiac adhesion proteins, are in their densest concentrations. Dietary effects on oral microbiome composition are real and underappreciated. High sugar intake feeds the most dysbiotic oral bacteria. S. mutans in particular runs on fermentable carbohydrates. The acidic oral environment that results from sugar fermentation selects for increasingly pathogenic species by killing off more commensal organisms that require a neutral pH. Nitrate metabolism is an interesting angle that's gotten attention relatively recently. Dietary nitrates, found in high concentrations in leafy greens, beets, and some other vegetables, are converted to nitrite by specific commensal bacteria on the tongue surface. The nitrite is swallowed, reaches the stomach and bloodstream, and participates in nitric oxide metabolism, which has vasodilatory and anti-inflammatory effects. This is part of why dietary nitrate consumption is associated with blood pressure reduction. The relevant part for our current conversation, the bacteria that convert dietary nitrate to nitrite are selectively killed by antibacterial mouthwash. Studies have shown that antiseptic mouthwash use abolishes the blood pressure lowering effect of dietary nitrate intake for hours to days after use. This doesn't mean mouthwash is bad. It means the oral microbiome is not just a disease risk. It's a functional system with metabolic roles, and indiscriminate disruption of it has consequences in both directions. The ideal intervention isn't to sterilize the mouth. It's to maintain a diverse, commensal-dominated oral microbiome with low pathogenic species load. Tongue scraping helps. Diet helps. Not smoking. Tobacco devastates the oral microbiome in ways that have been sequenced and documented with some specificity. Adequate hydration matters because saliva is the primary mechanical and antimicrobial defense of the oral cavity. Dry mouth creates conditions where pathogenic species proliferate much faster. And for anyone with known valve abnormalities, even minor ones, even ones picked up incidentally on an echocardiogram done for another reason, the conversation with their cardiologist about oral hygiene practices, and specifically about the tongue as a bacterial reservoir, is probably worth having. Most cardiologists will discuss dental cleanings and antibiotic prophylaxis. The tongue conversation is rarer, but it probably shouldn't be. The mouth is not a separate system. It's the beginning of a continuous biological pathway that runs through the bloodstream to the heart, and what lives in that part of the pathway, specifically on the posterior dorsum of the tongue in the biofilm that forms there, largely unaddressed, has a more direct cardiovascular relevance than almost anyone outside of specialized research circles currently appreciates. Your dentist isn't just looking at your teeth. They're getting a look at your heart, whether they know it or not.